Welcome to Medical Minutes. I am Dr. Craig Premack, and today is the beginning of July 2020. This information is accurate as to what we know today. It may change tomorrow, or as time may pass, we may solidify some of these ideas or completely dispute some or all of them. This particular Medical Minutes has been in working mode for at least a month. I've been thinking about it a lot. I finally sat down at the end of last week to compile all my thoughts and expect today's Medical Minutes to be a bit longer than usual. Let me know what you think. We are in the midst of the worst infectious pandemic of at least the last 100 years. Recently in Arizona, where I live and practice, we have had daily and weekly record numbers of people infected with the infectious agent SARS-CoV-2, a coronavirus that we've all heard of, that causes COVID-19, the disease. My medical practice for the last 14 years has been full-time weight loss or medical obesity management, a field now called obesity medicine. I've been a diplomate of the American Board of Obesity Medicine since 2012 when it was established. What we have learned as doctors is that obesity is a disease. It's a disease of too much body fat that leads to a multitude of related health problems that we're all too familiar with. Obesity, unfortunately, also gives a higher risk of developing severe symptoms and complications of COVID-19, even independent of having other illnesses like heart disease, diabetes, and high blood pressure. The CDC now lists severe obesity, which we define as a BMI greater than 40, as a risk factor for severe COVID-19. However, it's not entirely clear why obesity is associated with a more dangerous form of the disease, but I hope to summarize some of the leading theories out there right now. The other two major risk factors, besides obesity, that are at the top of the risk list are older age greater than 60, and male sex. On the next tier of risk is heart disease and diabetes. Here are some statistics. Number one, in China, where the outbreak began, data from 383 patients showed obesity was associated with 142% higher risk of developing pneumonia associated with COVID-19. Number two, in Seattle, a study of critically ill patients with COVID-19 made similar findings. This analysis found that 85% of the patients with obesity required mechanical ventilation, compared to about 64% without obesity. Moreover, 62% of the patients with obesity died, compared to just 36% of those without obesity. Number three, in one of the biggest studies I found, which looked at 428,000 people infected with COVID-19, 340 people needed hospitalization, of which 44% were overweight and 34% had obesity. Thus, obesity and overweight made up 77% of those hospitalized. In another study that looked at 12 million electronic charts, among 5,683 patients who died, 29% of them were overweight and 33% had obesity. Therefore, 62% who died either had overweight or obesity. Number five, last in one report from Italy, 99% of the deaths occurred in patients with 6 diseases: obesity, hypertension, type 2 diabetes, heart disease, kidney disease, and cancer. So why is it? Why does obesity increase the risk of severe COVID-19? First, we know that the progression of COVID-19 is largely dependent on the initial health of an individual and the immune response triggered by the infection. In the incubation phase, during this time, the patient does not present with severe symptoms, although it's in this stage that they are mostly asymptomatic, but it's also when they are contagious and can spread the infection. If their immune response is impaired or inadequate, the virus will multiply unchecked and destroy the affected cells, especially in organs that have a high expression of something called angiotensin-converting enzyme 2, or ACE2 cells. ACE2 is a transmembrane protein and is the main entry point into the body for many coronaviruses. In the lungs, an area of the body with a lot of ACE2 cells, These damaged cells induce inflammation in the lungs, and this leads to the classic symptoms of fever, cough, and pneumonia. It's this inflammation of the lungs, this severe inflammation, that is the main cause of the life-threatening disorders associated with COVID-19. There are many hypotheses and plausible explanations that explain more of what's going on. Number one of the most straightforward explanations is that patients with obesity have an increased risk because of the mechanical weight in their abdomens and on their chest walls. That they have a higher resistance in their airways, lower lung volumes, and weaker respiratory muscles that are critical in the protection against pneumonia. These factors make the individual more likely to develop pneumonia, and they place additional stress on the heart. In addition, associated diseases like diabetes, heart disease, and kidney disease, along with high blood pressure, high cholesterol, and prediabetes, can make people more susceptible to infections in general. Number 2, obesity itself is a chronic inflammatory state. Many years ago, we believed that fat, or adipose tissue, was just an energy storage organ. Calories came in, stayed there, and were called upon when needed, much like a gas tank. That was wrong. Our fat is really a tremendous organ which communicates with numerous parts of the body via hormones and cytokines. Cytokines are inflammatory proteins in the blood. Our adipose tissue, or fat, is part of the immune system and also the metabolic system, whereas through hormones like leptin, it signals the status of our energy stores to the brain. One of the dysfunctions of our fat associated with this disease of obesity is called adiposopathy, or sick fat. With sick fat, the fat sends out many different inflammatory cytokines to the body that worsen or even cause many of the associated diseases of obesity. Specifically with coronavirus is the fact that ACE2, the enzyme which the coronavirus uses to penetrate into the cells, is more common in people with obesity. This enzyme is found in many parts of the body, but the lungs are a primary place, and fat cells themselves express ACE2 at fairly high levels. It has been noticed in the past with other respiratory viruses, because of the high ACE2 level, that viruses can attack fat easily. They may last longer in fat cells, and viruses are shed more slowly from fat cells. Last, number 3. We see prolonged viral shedding and increased cytokine activation from adipose tissue that has already been inflamed in this condition we just talked about called adiposopathy in patients with obesity. This is considered a pre-activated state where the body is already sending out these inflammatory signals to the body. This engine, as we say, is already primed and doesn't need a lot of stimulation to just make more. It's kind of just like stepping on the gas pedal when your car is already warmed up. This unfortunately makes fat a good target organ for further immune amplification from pathogens such as viruses. This has been seen with other viruses in the past, such as H1N1 type A influenza, adenovirus 36, cytomegalovirus, and even HIV. In the common yearly influenza, the flu, this same pathway significantly prolongs the duration of viral shedding in humans with obesity. Some of the inflammatory cytokines that we see here are tumor necrosis factor alpha, or TNF-alpha, interleukin-1, IL-1, and interleukin-6, IL-6. All 3 are involved in a condition that many of you have heard called cytokine storm, or properly cytokine storm syndrome. Specifically in the lung, there is a delicate balance of pro- and anti-inflammatory cytokines that this resultant cytokine storm significantly disrupts this homeostasis, or the balance, leading to the lung disorders that lie at the heart of deaths from coronavirus. The cytokine storm overwhelms the immune system about 7 to 10 days into the disease, making the clinical course significantly worse. Along these lines, inhibition of IL-6 has already been proposed as a treatment in COVID-19, and the results of studies of one of the drugs that inhibit it, tocilizumab, are undergoing now. I want to tell you that not all hope is lost. What can we do? First, and most important, one thing that all of us can do at a minimum is wear a mask and practice good social distancing. Second, if you do have obesity or are overweight, start or find a program from an experienced medical professional who will customize a comprehensive medical weight loss program for you that focuses on the 4 important aspects of obesity medicine treatment. Number 1, nutrition. Number 2, activity. Number 3, behavior. And number 4, medications. If you have been unsuccessful in losing weight in the past, I do not believe that you want to redo whichever way didn't work for you in the past. Do you? Last, possibly we can protect ourselves against the COVID-19 cytokine storm by having a high level of cardiorespiratory or cardio fitness induced by exercise training, especially moderate intensity aerobic training, which may give us some innate immune protection. Exercise elicits potent and wide-ranging effects on the immune system, mostly which are anti-inflammatory. We know exercise protects against several chronic metabolic diseases, including insulin resistance associated with diabetes, and often helps in the treatment of obesity. Exercise also improves the immune response to vaccination and improves various immune markers in diseases such as cancer, HIV, heart disease, cognitive impairment like Alzheimer's, and obesity. Furthermore, exercise training may reduce the risk, length, and severity of viral infections. Thus, at least hypothetically in humans, but proven well in mice, exercise may counteract, at least partially, the detrimental effects of the binding of the coronavirus to the ACE2 receptor, reducing the inflammatory response in the lungs. To summarize, number 1, we're in the midst of the worst infectious pandemic of at least the last 100 years. We have had daily and weekly record numbers of people infected with SARS-CoV-2, this coronavirus that causes COVID-19. The CDC now lists severe obesity as a risk factor for severe COVID-19, along with age greater than 60 and being male. Number 4, specifically with coronavirus, is the fact that ACE2, the enzyme which the coronavirus uses to enter into the cells, is more common in people with obesity, both in the lungs and in the fat cells. Number 5, the best things we can do are number 1, at a minimum, wear a mask and practice good social distancing. Number 2, start a program from an experienced medical professional who will customize a comprehensive medical weight loss program for you that focuses on the 4 most important aspects of a medical weight loss program. Number 1, nutrition. Number 2, activity. Number 3, behavior. And number 4, medications. If you do not live in Arizona or do not want to travel here, you may find a list of these professionals via the clinician finder at www.obesitymedicine.org or on my website, scottsdaleweightloss.com. And last, begin a cardio-focused fitness program aiming for moderate intensity aerobic training, which may give us some innate immune protection from coronavirus. On my website, in the text, under the video link, I will include several links to a BMI calculator, the clinician finder, and an exercise program called the Couch to 5K program, which is a good place to get started moving if you're currently inactive. Thanks for watching.